Good evening. I'm Ashley Reef. I'm the nurse coordinator for the Adult Congenital Heart Disease program here at Houston Methodist, and we're happy to have you here for DeBakey CV Live. We have a great program for you this evening. We'll be discussing patient transition from pediatric to adult congenital care. I have two really special guests with me today. First, we have Marissa Mendoza. Marissa is a pediatric cardiac ICU nurse and a CHD patient. Thanks for being here, Marissa.
Thank you so much for having me.
And we also have Anna Jaworski. She hosts the podcast Heart to Heart with Anna, and she's also a CHD mom. I'm so excited to have you here, Anna. Welcome.
Oh, thank you so much. I'm excited to be here with you.
We want tonight to be an interactive experience, so please send us any of your questions and we'll answer them as we discuss the often difficult journey of transitioning care. All you have to do is text DeBakey to the phone number 37607. That's DeBakey, D-E-B-A-K-E-Y, to 37607, and we'll answer your questions. Our objectives for tonight are discussing the best practices for transition to adulthood for adolescents with congenital heart defects. We want to discuss optimization of quality of life and life expectancy for young people with CHD. And finally, we'd like to talk about the timing of transition to adult care. So with those in mind, let's get started. I want to start with you, Marissa. So you're working on your clinical nurse specialist, and as part of that, you did a project on transition of care. Can you tell us a little bit about that?
Yes, sure. So it's a topic that I've been interested in for years now. I've been working as a pediatric cardiac ICU nurse for about a year. But again, this topic is still something that I've been interested for many years. What I really looked into was how the role of a clinical nurse specialist could help the transition between pediatric to adult congenital heart disease care. If you would like, I can share my PowerPoint with you now.
Great, we'd love to see it.
All right. Okay, so the topic of my project was really the role of the clinical nurse specialist, which is, for many that don't know, an advanced practice nurse really based in education, the role of the CNS in congenital heart disease transitional care. So for those that aren't familiar with congenital heart defects, CHD is the most common birth defect impacting every 1 in 100 births. The acronym for it, like I just mentioned, is CHD, otherwise termed congenital heart defects or disease. It's a structural abnormality of the heart which occurs while a baby's still forming in utero. Many CHDs require at least one life-saving surgery, sometimes immediately following birth. Now, don't get me wrong, there are a few people I've met that haven't required any type of open heart surgery, but then there are others that have had multiple, like myself. CHDs usually require lifelong medications, follow-up care. You may have some restrictions, and like I mentioned, subsequent surgeries. Many times it occurs in combinations of 2 or more defects, and it can impact other non-cardiac organ systems, such as your liver, your lungs, reproductive system. Really, the list is endless. So here I just have some of the more common congenital heart defects you may have, just to throw them out there and jog our memory, I guess. Moving forward. So transitional care and what really needs to be changed. So for those that don't know, transitional care is really when a CHD patient goes from their pediatric cardiologist and transitions over to an adult congenital heart disease specialist. As you'll see a few bullet points down, all patients with CHD are recommended to see an adult congenital heart disease specialist at least once in their life. Due to recent medical advancements in recent decades, I would say there are now more adults living with CHD than there are children, and that is an awesome accomplishment. But because of that, ACHD is considered a newer specialty. With that being said, many CHDers, there's really one of 3 options. Three options here. They could fall out of care or have lags in care, so they won't see their cardiologist for years at a time. They may stay under the care of their pediatric cardiologist for years and years and years. And you think about it, is that really appropriate? For example, maybe a woman of childbearing ages is still being seen at their pediatric cardiologist and they're pregnant. Is that the best place to be? I'm not an expert, but just something to think about. And then lastly, some people that do end up transitioning may find themselves in a general cardiologist's office, which also isn't really the most appropriate place to be. And my project is looking to see if a clinical nurse specialist can help this process. At the bottom, I have something that anyone would be familiar with that's seen at a children's hospital as an adult, where you walk in and they ask for your child's first and last name, and I'm like looking over my shoulder. I don't think I brought one of those. I don't have one. I'm the patient. It's me today. So that's a common occurrence. So a PICO question, like you mentioned, this was a project for my school. So PICO questions looked to see what population, intervention, comparison, outcome, and time frame, how those can all be impacted. So really with mine, we're looking at if patients with congenital heart defects are transitioned from pediatric to adult care, would they show improvements related to outcomes, quality of life, compliance to follow-up care, and accessibility of care when an advanced practice nurse and/or clinical nurse specialist serves a role within their transition process. So that was really the big question I'm trying to answer here. This is a really big chart with a lot of information. I'm just going to briefly touch on it, not very much in detail. So to complete my project, I used 5 articles. There were many more that I found. I actually narrowed it down to 23 at first, but we only had to include 5, so that's what I have here. We have a variety of types of articles. Some are surveys, some are different studies looking at patient numbers related to ICD codes and diagnoses. And then we have a few articles that are labeled expert opinion articles. Now, personally, I think they provided some of the best information, but it was all really worthwhile. So we'll get more into the details further on. This is just another table for that, which really puts together all of my articles. But like I said, we'll touch upon that in the next slide here. So in conclusion, and there's going to be 4 bullet points here that we'll talk about in depth. So what I found was that there's really an increased need for outpatient ACHD centers. Now we'll take that and we'll go piece by piece with this. So outpatient ACHD centers, as we've heard, ACHD is really a new subspecialty. There's not enough ACHD centers across the country right now to support how many adult CHD patients there are. So along with that, not only do we need more outpatient centers, but that also means we need more areas within facilities that can house CHD patients for procedures such as cardiac caths or open heart surgeries or just hospital admissions due to critically ill diagnoses. So it cascades. It's not just the need for a new doctor's office, but it's the need for these centers, these encompassing centers that really can provide complete cardiac care to the congenital heart defect adult patient. Along with that, what would be another important key role is for the clinical nurse specialist to serve a role in the referral process. What I found with my studies was that many individuals knew they needed either themselves or their child to be transitioned over to an adult congenital heart disease specialist. However, they were never referred there, so they never really knew when to go. So by increasing the referral process and increasing the number of outpatient ACHD centers, we'll see less hospital stays, increased quality of life due to the less hospitalizations, and increased accessibility to care, because with these referrals, more people are able to go to more offices. Next, we really saw a lack of education, not at the fault of the parent or the CHD patient, and also not really at the fault of the medical providers themselves. Really, what we're finding is there's these gaps in education. While the parents and the patients may understand the need for follow-up care, many patients experience very good periods of health where they have a false perception of being cured. So because of this, they don't think that they need to follow up with their cardiologist until something goes wrong. And then many times, by the time they're seen, there's a lot of things wrong that they didn't really know about. So the clinical nurse specialist has a role to educate parents and patients on the need for transitional and lifelong care to help prevent gaps in care. By educating parents and patients, sorry about that. The CNS can provide educational resources to help with this process, things such as personal health passports, lesion-specific handouts, and more. I'm actually in the following slide going to show a few examples of resources from the Adult Congenital Heart Association. And then finally, the CNS is actually recommended to develop a relationship with each patient themselves to really have a key role within an ACHD center to help facilitate self-management skills with patients. When you think about it, they're used to seeing their cardiologist and listening to all of the difficult medical jargon, and they have their EKG and their echo and their stress test, and then they go home. But what could really help kind of tie it all up in a bow is if they see one more person at the end of their visit, the nurse or the clinical nurse specialist, to help them understand what they just spent their day listening to, what their EKG really was meant to show, what about their echo. And these self-management skills will not only help the patient, but it'll help their health down the line because they'll understand how to be their own self-advocate once they learn more about how they can do that for themselves. Some resources that I wanted to show examples of, as I mentioned, the personal health passport. These are all from the Adult Congenital Heart Association, and they were actually specifically mentioned in a few of the articles I read, which was really, really interesting. The personal health passport can be carried around in a purse, a wallet. You can keep it in your car. You're really just supposed to keep it on your person, and it's really for like in case of emergency, or it's really just an awesome resource to have with a bunch of little pieces of information. If you want to take a look here, you can check off some boxes for any type of histories you may have. You put your demographic information in. I think this part is really cool because no one's heart looks the same with the same diagnosis or the same surgery. Everyone's is a little different. So your cardiac team may be able to help you fill in your diagram here. And then of course, in case of emergency page, what I think is really interesting about that is that not only could you list your family members in case of an emergency, but also your ACHD clinic, just in case you're not at your usual hospital or you're on vacation and far away from home. So that seems really helpful to me. Thankfully, I've never had to use it, but I do have one of these. The center handout we have here is one example of a lesion-specific handout. It's actually the congenital heart defect and surgery that I've had, the single ventricle Fontan, but the Adult Congenital Heart Association has a ton of lesion-specific handouts, and it's not only helpful to the patient, but the family members and friends and whoever wants to learn more about how they can better support their friend, family member, or spouse with CHD. And then lastly, we have a clinic directory over on the right. Because this was a project for school, my school's in Pennsylvania, so I have it filled out for PA here, but you can put in the state or the zip code, click filter, and then it will show you all of the ACHD centers where you're at in the state that you're in. So this is helpful if you're in a new area and there's something wrong and you need to go see an ACHD specialist, or if you're looking for a new ACHD specialist. So those are just 3 examples of the many resources that the clinical nurse specialist can help by sharing. I'm going to stop sharing my screen now.
I thank you so much, because I will tell you that those lesion-specific handouts I use with just about every one of our patients. As we're doing education, I think those are a great take-home. I usually, I try to go through every section with them, but then I also say, take this home, because I think, nobody is going to absorb all of that information that you get in that one day in one sitting. So I think that hopefully helps generate questions in their next visit. So again, tell us a little bit about your specific heart defect. I know you said you are now a Fontan. Tell us about your specific lesion, if you don't mind.
Sure. So I was born with 6 complex congenital heart defects. I'll list them. I had a ventricular septal defect, pulmonary atresia, transposition of the great arteries, but it was congenitally corrective with ventricular inversion, dextrocardia, and bilateral superior vena cavas. I had my first open heart surgery at 3 days old, the BT shunt. My second open heart surgery at 8 months old, the hemi Fontan. And then my third and final, as of now, open heart surgery at 22 months old, the Fontan completion. And I do think it's worth mentioning that my heart condition was not diagnosed until a few hours after I was born. So I know it can go both ways, but we did not know until postnatally, as they call it.
That's very interesting. With all of with that combination, that you look great for for somebody that has had all those and is now a Fontan. Anna, tell us. I know you are a CHD mom, so you have a son that has congenital heart disease. He's also a single ventricle. Tell us about his defect and when he was diagnosed.
He's actually really similar to Marissa. He also has a single ventricle heart. He had an ASD, a VSD that was so large there really wasn't much of a septum between the two ventricles. He had a PDA, a PFO, an ASD. So his heart was kind of a Swiss cheese heart, lots and lots of holes, so he was never blue. And just like Marissa, he was not identified or diagnosed, not even 3 days. He was not diagnosed until his second month well baby checkup, even though my husband and I kept saying for those 2 months that something was wrong, and I kept taking him back to newborn follow-up. So he looked good enough that they just kept excusing all of our concerns away with different labels. So I was concerned that he wasn't nursing, and they said, oh, well, he came 3 weeks early. He still thinks he's inside of you, and he's just a sleepyhead. Don't compare him to your first son. And I was concerned about the jaundice, and they said, oh, it's breast milk jaundice. And even though I kept putting him in the window for sun baths, they weren't worried about it. And my husband was worried about his breathing because he was breathing so fast, and you could actually see a cleft in his chest. And they said, oh, that's newborn breathing. So even though we kept having concerns, and I would say we knew something was wrong, nobody validated our feelings until he was 2 months old, and he was then labeled failure to thrive. And they did a chest x-ray. It still amazes me that for 2 months he never had a chest x-ray. He never had pulse oximetry put on him. Had they done one of those two tests, they would have known that something was wrong. But so finally at 2 months of age, they did an echo, and they said, we've got to get this kid out of here. And the next thing we knew, we were in an ambulance going 3 hours away from home to San Antonio. And he had, at 2 months of age, he had a modified Norwood operation. And then 8 months later, he had a fenestrated Fontan. So he went straight to the Fontan. And then at 17, he had the extra cardiac Fontan. So his old Fontan was taken down. He had an extra cardiac Fontan. And then he also had a modified Mays procedure to try and take care of some arrhythmias that he was having.
Okay. Now, after your son had the Fontan, when the doctors approached you about that, when did they start to really talk about transitioning care? Did they talk about the fact that he would need further procedures down the line?
So do you mean the first Fontan or the second one?
Yes, the second. I'm sorry. Yeah, the second.
Well, when he had his second Fontan, he was 17. And did they talk about more procedures? I mean, I think because I'm such a strong advocate and he hears me talking about the different podcasts that I'm putting together and the books that I've put together, he knows that transplant is a possibility, that pacemakers could be a possibility. I don't think he really thinks that it's going to happen to him. But as far as the answer to your question, did they talk about transition care? No, not really.
Okay.
He's 26 years old now. That was 10 years ago. And they just, 9-10 years ago, they just really didn't talk too much about it with him. I think he was very mature for his age. Mm-hmm. And he came in and, you know, probably because he's had to attend conferences where he's heard his mother talk about his heart defect, and he's seen the books that I've written, and he's had to listen to a lot more than most people have. He knows the name of his heart defect and has known it from the time he was a really young person. And I think he was more in tune with what he had, but I don't think it really struck him until he had that Fontan revision. He didn't remember those first two surgeries, and so that scar was just part of him, but I don't really think it meant to him I know it didn't mean to him what it did to me. He didn't have any memory of those surgeries. And to be totally honest with you, I think he kind of thought I was exaggerating how things were, because he felt the way he felt. That's just the way he always felt. And
Right.
he didn't understand what mom's making a big deal about. And then when he was in the hospital and he was suffering from pleural effusions, and he saw another young man who was a little bit older than him, who was also in the children's hospital, because that's where they took care of them. And they were the only two big people. Everybody else was 2 years of age and younger. And then here's my 16-year-old and a 19-year-old that were in there, both Fontaners, both having different issues. Then I think it finally hit him what I had been saying for years, and how he needed to be aware of what was going on. And I think seeing the other young man really had an impact on him, because the other young man had totally fallen out of care. He was also a Fontaner. He didn't know the name of his last procedure. He didn't really understand what was happening to him. And I think that kind of struck Alex, but not to the point where he is now getting the care that he should be getting. He has had a lag. I like that term, just a lag. It's been over a year since he has seen a cardiologist. Every time I ask him about it, he tells me it's going to happen, but it hasn't happened yet.
And how about for you, Marissa? Do you remember a time when they started talking to you about transitioning to adult care, or did your parents say that there was a point in time when that topic came up?
Sure. So I love my pediatric cardiologist that I grew up with. However, I don't believe she had ever mentioned transitioning. Actually, she was more than happy to keep me on as her patient. She always said, "Oh, I have patients in their 40s and 50s and 60s. You can stay. And I love her. But I think, honestly, it was from my own advocacy efforts and Facebook groups that I'm in that I learned about the need for transitional care. And I think I transitioned around the age of 19 or 20-ish, and I was hesitant with it because my pediatric cardiologist is up until that point, the only one that I've had any memory of. She's absolutely awesome, but my parents and my mom specifically would always say, "Oh, what happens if you need some emergency surgery and it can't be at the children's hospital?" I saw all kinds of specialists at the children's hospital, and they all kicked me out at 18 except for cardiology. So everything else was transitioned over to the adult hospital except for cardiology. So she was right. Just in case something were to go wrong and I were to need some type of care that wasn't even related to my heart. So that was really the catalyst for my transition to adult care. It wasn't always the easiest process, and sometimes I still kind of wish that I was still in pediatric care. However, it's definitely the right place to be.
Right, and I know that struggle has to be extremely difficult. I mean, I came from working in the pediatric world, and I know how close the not only the parents but the patient become with that pediatric cardiologist. I mean, oftentimes that's the person who was part of saving your child's life or saving your life. So I can only imagine that transition is very difficult, having to leave. It's probably almost like leaving a parent. In a sense, because they had so much control over that portion of your life. So Anna, I know you said that there wasn't really a transition for your son. So now that he's an adult and he's now is having these lags in care. So do you feel as a parent that do you feel like you push him to be getting the care that he really does need, or do you feel like you're able to kind of let him navigate his own path as far as his transition goes?
That's a tough question. And it's kind of funny though, because I was just thinking, when did he transition? And really, when he was having that extracardiac Fontan operation, he was 17, and the doctors would not let my husband and me make decisions for him. In Texas, when you're 17, you're considered an adult. And even if your parents are there, even if your parents are paying for the operation, they talk to the patient, which of course I wanted them to talk to Alex, but I could see that my son was hurting, and he's a Texan. He's a male Texan. He did not want to admit to these pretty young female nurses that he was hurting and that he maybe needed some more pain medication, but his blood pressure was higher. I mean, he had clinical symptoms that he was in pain. And I taught to him about being an advocate for himself. And he usually is a pretty good advocate for himself, but I think it's different when there's a pretty young female nurse who is taking care of you. So I guess in a way he was kind of thrown into the transition just like that without really having the benefit of formal education. I mean, I had been teaching him all his life, probably more than a lot of kids get, but I still don't think that it was the best way for him to all of a sudden be told, okay, now you're an adult and now you're in charge and now we have to listen to you. And if you say you're not in pain, then we're not going to give you any pain medication. So do I still worry about him? Yes. But the one thing that I have to say about my son, and Marissa, I kind of get this impression from what you said about yourself as well. My son knows his body. Mm-hmm. He really knows his body. And he knows if there is a problem. Not that he'll always admit it, but he is really attuned to his body. And I'm really proud of him for that. So sometime after he had his Fontan revision, he had been put on a new medication. And then he had a Holter monitor months later and wanted to go on an educational opportunity overseas in Germany. And so he had his Holter monitor. Everything seemed to be okay, I guess. They let him go to Germany. And after he was in Germany, the cardiologist called me in a panic saying, oh my gosh, he is having bradycardic episodes when he's sleeping. And we need to get him back yesterday. And I called my son in Germany and I said, honey, they want you to come back. First I asked, is this life-threatening? And the cardiologist said, no, probably not life-threatening, but we want to get a pacemaker in him as soon as possible. And he was really adamant about that. Well, my son decided no, he was not going to do that. He was not cutting his experience early, that it really wasn't a problem. He looked up online the new medication that he was taking and saw that one of the side effects was possibly that it could cause bradycardia. And he decided that that was probably what was going on. And he continued with the next month that he had planned for this internship and came back and told me he was not getting a pacemaker. And thankfully, Dr. Wilson Lamb took him on as a patient and was very, very respectful of Alex's research that he had done and of his own feeling about his body, and took him off the medication, had another Holter, and Alex was right. When he stopped taking that medication, now he had to wait until the medication got out of his system, but once it was out of his system, he stopped having those bradycardic episodes. So I was really proud of him that he was able to be an advocate for himself, do his own research, stand up for himself. He let me drive him to see Dr. Lamb because we had never been there before, but I was not allowed to go in because he said, Mom, it's my heart. You've been training me all my life. I can do this. And when he came out, he told me exactly what had happened. So I think he does his best to try and make me not feel anxious. And he knows I'm the record keeper in the family, so he gives me all the paperwork and we talk about it. So I think he's probably better than a lot of other patients that I've heard about as far as keeping up with those records and all that, but he still has too laissez-faire an attitude to make me really happy.
Well, I think, being an advocate for themselves, I think is really important for a patient. And often with patients that come to us that are just at that transition point, I think struggle with that. We usually request that they bring a parent with them to their first visit, just in the interest of really getting a complete history, because very often, we have patients that don't even know what their defect is or don't understand what it is. Very rarely do we get somebody like Alex who, like you said, can really knows his defect.
But I'm also a writer, and so I put together a booklet for him that had all of his surgical notes that had a one-page summary of his heart defect, the surgeries he had had, where he had them. And in the 2.5 hours that it took us to drive to his appointment, I was quizzing him. So he was totally prepared, and I think that was really good for him.
Yeah. Well, and I think being able to take ownership is really important, because so many things from birth, everything surrounds that defect, that congenital defect, and then it becomes your whole life. As we were talking about, if some of that lapse in care is likely, I don't want to worry about my heart. When it, I always try to impress to patients that it becomes, that's your chronic illness. It's the same as if you have diabetes or something along those lines, where you have to follow up with your doctor. But with your record keeping, I love that, because I think that's another piece of that transition that's really important. I usually tell my patients to keep like a binder of their most recent imaging, a one-pager. If they have a picture, very often there are, pictures that are from childhood, post-surgery, that are often made. I know we used to do those at the bedside in the ICU, and to make sure they have a copy of that. And then, of course, Marissa, something you said when you were talking about your project is, the ability to, be able to have a business card or the name of your congenital program, because occasionally we'll see a general cardiologist that is maybe looking at what's going on with the patient one way, when really it needs to be looked at in the frame of that congenital defect. So I think,
right.
Keeping those records is so important. And how do you keep yours, Marissa? Do you keep an actual folder, or I know some people keep a thumb drive?
I have a binder separated into different specialties, and then from that point forward, I have them separated into lab work for each doctor and imaging and things like that. And it's been very helpful, just because, I am my own advocate. So if I go to a physician's office, whether it be my cardiologist or somebody else, and they're questioning what I'm saying, I have the specific piece of paper I can pull out and show, I know that it's this, or I know that it's that, or something along those lines. So it was something that I put together right around when I transitioned. The ability to have access to like an online personal health account, I guess it's called, for the hospital I go to, is super helpful, because I can go on and see all of my results and message my physicians, and that has really enabled me to keep accurate trackings of everything that I have, really.
Yeah, and I think that's important as well, because I think trying to get pediatric records often is difficult, because they're going back to physical paper. That's something that isn't necessarily electronic. So they're looking for physical paper records of of procedures. And often we're told, oh, sorry, those were destroyed, and that's tough, because if very few parents remember maybe exactly what happened in that first surgery. So
right.
I think that being able to maintain your own records as much as you can, because often I've run across parents that have original, pictures that are so old, and you can tell they've been handled so many times that they're, almost see-through. But they're a great resource for us, because, you have to know where everything started to be able to continue care.
Right.
So as far as education goes, I know you had addressed that a little bit in your presentation, Marissa. What education do you feel like on the pediatric side is most important prior to a transition period?
I think the most important piece is for parents and for CHDers themselves to understand that this is a lifelong illness. There's no cure to congenital heart defects. I had a Fontan, but my heart definitely doesn't look like somebody else's in the next room of mine. So it's very different. There will always be possibilities of complications down the line. And as difficult as it is to hear that, and accept that it's reality. And you have to continue going to follow-up appointments and follow-up care, even if you don't want to, just because there's always that chance that there could be something down the line.
And how about you, Anna? What do you feel like is a very important educational topic prior to transition, kind of in that pre-transition phase?
Well, I think first of all, telling the parents that this is a lifelong condition. I can't tell you how many parents have told me that the doctors told them their children were fixed after they had their third procedure or fourth procedure, or whatever number they want to say that, oh yeah, now my child is fixed. And so if you think your child is fixed, then you're not going to impress upon them that this is a lifelong condition and that they need to continue that follow-up care. So first of all, using that term, this is a lifelong condition, this is a chronic condition, I think those unfortunately have a very negative connotation to them, and it seems really scary. So if we can start talking to them early and let them know this is no different than diabetes or some other lifelong conditions, ADHD. I mean, there are so many different conditions that people are used to hearing about and that will require possibly surgeries, probably some kind of medication, and definitely some kind of follow-up. Then I think that at least gets them in the right mindset. I think that a lot of people are not in the right mindset because it's terrifying to hand your child over to a physician knowing that your child may not come back to you alive. And so to do that over and over is very traumatizing, not only for the parent, but I think that the children get a certain amount of that as well. And I think there have been a lot of studies to show that the parents and the children can suffer from PTSD. So I think we need to give them some coping strategies and talk to them. I don't think enough of our community is in touch with the kind of psychological help that they may need, or mental health that they may need to help them to have the best quality of life possible. So I think maybe starting in that arena and talking about the mental health and talking about living with a chronic illness. We say heart defect all the time, we say CHD. I don't always hear people saying chronic illness.
I absolutely agree with that. I mean, I think starting early or relatively early in childhood to do education with parents and start there, but also being able to talk with the patient about this is what your heart looks like. These are the things that, in an age appropriate manner you may or you are going to go through, and that it is something that you're always going to have to see a doctor for. I think if that kind of pre-transition phase is done well with education, and then as through maturity, being able to talk about things that are just of concern to a non-CHD patient of that age. I think sometimes those things are missed because everything's so focused on what's going on with your heart, what's going to happen with your heart. So I think from my standpoint, that's what I see. We get a fairly large number of patients that come to us and they've had a gap in care and they're coming with symptoms, but they don't know the answers to some of the questions, birth control, for instance, or cardiac issues that are non-CHD related, just age-related cardiac issues. Things that, the average non-cardiac or non-congenital person worries about, but they are kind of clouded by the CHD diagnosis in our patient population. And I think that self-advocacy just comes out then as well, being able to ask questions. And I think part of that maybe comes from in the pediatric setting, a lot of times because of being so overwhelmed with these big terms and these big surgeries, the physicians and the care team kind of drive what's going on with the patient and the patient's care. And then you get to adulthood and the patient's asked to drive and the patient doesn't really know how. Anna, I know you mentioned with your son not being able to make an appointment, not being the one that's making the appointment. And, I think it's hard to hand those reins over to the patient and have them, suddenly say you're in charge without some of that pre-transition preparation. for sure.
Yeah, and I thought I did a good job too, to be honest with you, Ashley. I had him calling in his medications to the pharmacy from the time he was, 10, 11 years old. I had him starting to do that because I knew this was something that he would need to be familiar with, and being able to say what his medications names were and knowing
Right.
what the pills were and what they look like, all of that kind of thing. So I thought that I was doing a really good job, but to be totally honest with you, I think Alex is feeling so good right now. And he's so happy with his life. He has a really good quality of life. He's working a full-time job. He has his extracurricular activities that make him happy. I don't think he wants to think about his heart defect, and I don't think he wants to see the cardiologist. I think it's that simple.
Right.
Yeah.
And we had talked before the show too about that feeling of invincibility that comes with being in your early to mid 20s. And if you're not having symptoms, particularly for those patients that are considered or told to be fixed, that that their heart is fixed, I think it's probably nice not to have to worry about it if you're starting your first job and you're starting a career, or you're going to graduate school, or whatever. But then of course we talk about how when you end up later in our adult world, a lot of times that causes its own issues as well. Marissa, have you had any kind of complications with your Fontan at this point?
I've had a few. Actually, just recently, just last week, I had a cardiac cath, just for some oxygen issues, lower oxygen issues with my Fontan. But other than that, and fingers crossed, knock on wood, all of that, it's been pretty stable for this point up until now. But yeah, so I haven't had too many, although it's always still kind of in the back of my mind, just because every now and then I'll feel a palpitation or a PVC or something along those lines. And then I remember, when did I last see the cardiologist? When do I need to go again? But thankfully, very thankfully, I have not had too many complications from my Fontan, no.
Do you feel like you've had, I know obviously you come with probably more education than the average Fontan patient, but do you feel like you've been preemptively educated on what to expect?
I do think so. So my mom is also a nurse, and she was usually the one that would always take me to my pediatric cardiology appointments. And sitting there, she and my cardiologist would be speaking like a different language to me pretty much when I was younger. Now it all makes sense. But I think with her knowledge and advocacy and tendency to ask a million questions from the very beginning, I have had the opportunity to have a pretty good idea of what to expect in the future. And then when I kind of took over control of my care, I was already introduced to how she asked those questions and how they talked about the future. So I was able to do the same with my adult congenital specialist. But I would say for the most part, I think they've been really good about talking about things down the line.
Did your pediatric cardiologist interact with your adult congenital specialist as you were kind of transitioning from one to the other, or do you feel like there was a pretty distinct break?
There's been a very distinct break, and it did make it pretty complicated, just because they would ask me for certain things from my pediatric cardiologist, which then I had to call and leave messages, and someone would call me back and make it a whole process. So that, I was actually just talking to my mom about that the other day, and it's part of my project too. A lot of what I found is it's really helpful if for your first meeting or two, even if it's through Zoom with your new cardiologist, to have both of them there. So that way everyone's on the same page, all of the questions are answered. It's kind of a little trickier because you're coordinating care with two physicians or nurse practitioners or healthcare providers instead of one. But I think it does make it a lot more challenging for the patient when during that transition process, the two physicians don't really chat. I love them both separately, but I don't think they've chatted about me, which that did definitely make it complicated.
And how about in Alex's case, Anna? Do you feel like the pediatric and adult providers had contact and were able to kind of share information?
Absolutely. When Alex was told he had bradycardia and he first saw an adult cardiac specialist, they were in constant contact with each other and shared test information with each other. So I really do feel blessed that way, even though they were 2.5 hours apart in totally different cities, different hospitals. They were very good at their communication.
What's been the thing for each of you that has been the biggest challenge with transition?
For me, I would say, and I know I look at it from different perspectives just because I'm also a nurse and I work with the pediatric patients, but for me, I feel like in the pediatric world, you have such a good relationship just because that pediatric cardiologist was with me from the time I was 5 until I was 19 or 20, and she went through so much with me. And then I went over to the adult hospital, the giant hospital facility where there's a ton of patients being seen there. And I kind of feel like a number sometimes. When I'm speaking to my cardiologist one-on-one, we do have a good rapport and a good relationship and things go well. But when I'm trying to get in touch with somebody or just relay information, it's not very personal, I guess. I just feel like a number in a big hospital system, really.
And how about you, Anna?
Turning the reins over to my son was definitely the hardest thing for me, although he was really great when he was 18 and I was not permitted to go with him. He said, well, I had a very unusual circumstance because I had been tutoring his cardiologist's son in mathematics. So I had a relationship with him outside of the office. And I won't say we were friends, but we were well acquainted because I was the math tutor. So Alex went ahead and put in writing that the cardiologist could share information with me and that if I had any questions, that it would be okay for him to answer my questions. So that was really important to me because like I said, I had been the record keeper. And it's just like Marissa said, we had known him for over a decade. He had been a big part of Alexander's life, and now he's retired. So we don't even have the benefit of what you were saying, Marissa, where both of the doctors can be on a Zoom call together, unless maybe I could go ahead and call him and see if he would be willing to do that. I think that would be a really great solution. But Alex has not found a specialist that he's going to on a regular basis right now. And I think that's a big challenge right now is he has a lag in care, and right now he doesn't have a cardiologist at all because his cardiologist is retired.
What do you feel were kind of things that were handled well in the transition process? I know, Anna, you said that Alex didn't really have much of a transition process. It was fairly abrupt, but was there anything that you feel like went well with his transition?
Well, I will say that for years, his pediatric cardiologist did a really good job of talking to him and not me. I mean, I would be in the room too, but his focus was really on Alexander and in having a conversation with Alex. I was allowed to ask questions, but he really did do a good job of talking directly to Alex and asking Alex how he felt about things and not talking through him, but actually talking to him. So I think that's really good. And I think that enabled Alex to feel like he could be an advocate for himself. So I think those were all positive things. And he never told Alex he was fixed. He always made it very clear to Alex that this was something that would take his attention for the rest of his life.
I think that's so important because I think when we talked about that relationship that a patient and a family have with that pediatric practitioner. And I think that earning of trust on the adult side is difficult. And if you have a pediatric physician that's telling you your heart's fixed, and then you go to the adult side and they're saying, well, no, we wanted, you'll need X, Y, and Z. I think it's hard because you've built that trust with that pediatric provider. How about you, Marissa? What do you think went well?
So my very first appointment, I sat down in the office with my new adult congenital cardiologist, and the very first thing she said was, explain everything that you understand, and we'll fill you in with what you don't know. And I'm lucky to have the knowledge background that I do to where I understand it to a bit of a deeper degree. But for those that don't, and even for me, that was the most helpful thing that anyone could do, by starting to assess my knowledge, to see what I knew, to see, oh, did I not know about this lifelong issue, or is this something that I'm worried about and I really shouldn't be? So that was, I can't even imagine a better way for her to have started off our first appointment together and continued our relationship like that. It was very, very helpful, and really helped me establish trust with her, like very, very quickly with our first meeting.
That's fantastic. That really is. That's a great jumping off point, I think, for an adult, especially at a first meeting, to really assess and give you the ability to show what you know, not just assume that you don't, because maybe they've met other patients that didn't have a great understanding. That's wonderful. Well, we have a question. What do you do if there really isn't a true transition program? So what did you find, Marissa? We'll put you in the hot seat first. What did you find were some things that maybe would be helpful if there isn't a true transition program?
So I think if I'm lucky, I live in New Jersey, but I'm right outside of Philly. So I don't think I realize it, but there are so many awesome hospitals around here, and I'm very thankful for that. But for other people who aren't as close to like a hospital hotspot like I am, I guess I could say, the very first thing you'd need to do is find a facility to transfer over to if like your children's hospital isn't connected to an adult congenital hospital. I guess I would recommend maybe asking the pediatric cardiologist for any recommendations for an adult congenital specialist. And you may be surprised, my surgeon has been retired since, I don't know, I think I was 11 or 12. I'm 24 now. My mom will email him with questions anytime, and he responds back, I think usually in like 5 to 10 minutes. So though that may be unconventional, there are always resources for you available, even if it's your old cardiac surgeon from 22 years ago. So I would just try to utilize all resources that one has at their fingertips, really, to help find a new program. And really, I think it's just about finding that care, the accessibility to care I was talking about in my presentation.
Well, you just made me feel really old, because I know you're a cardiac surgeon and he was still practicing, and I was a nurse. So Anna, how about from you? What do you think? What pointers would you give someone?
Well, I think what Marissa said is right on point. I think also having that binder or thumb drive or whatever you can get. Before Alex went off to college, I put together a thumb drive that had all of his most recent surgical notes. It had a CT scan, it had his echo, just in case there was an emergency, because he went to New York City for college, which is quite a jump from Texas, and I was really nervous about that. But we found a good ACHD doctor in New York and made contact. His doctor made contact with that doctor. Alex never even visited him, but I knew he was there in case he needed to. When Alex came home for the holidays, he had his appointments with his regular cardiologist. So we were just really lucky that he didn't have any bad experiences while he was in New York. So I think having that thumb drive, having that information, the binder, like what Marissa said she has put together, I put together for Alex the same kind of thing. I just think that's invaluable, because it's right there at your fingertips in case you get nervous, in case you forget what was the name of that surgery or what was the name of that surgeon or what date did I have that. It's all right there in black and white for you. And I think that helps make the transition go a little bit easier, because you're not racking your brain. And I mean, in the case of Alex and Marissa, they don't remember those first surgeries.
No.
So
Right.
It's just what their parents have told them over the years that they have to remember. So having the written documentation really does make a big difference.
And I have to say, from looking at it from the adult side, as we're having patients transition over, I think a really important thing is that ACHA database, being able to research physicians that way and see, where are the centers that have shown, have demonstrated that they provide really quality congenital care. Because I think if if a family isn't given a lot of leadership on the pediatric side about, maybe there isn't a referral that the pediatric physician can give, that ACHA website, I think, is a really fantastic resource for where patients can find care. And Marissa, I know you mentioned as well, when people are traveling, when our patients are traveling, I often suggest that they go to the website and look for those things, because it is so important. Just so you have a name, that's what I tell them. I'm not saying to you something's going to happen to you, but just so you have a name, so that you don't end up in XYZ hospital and they don't understand what's going on with you, and then you're how many hours away or how many states away, and being able to have contact with our program and our program to help manage would be so that much more difficult. So I guess what would be one piece of advice that you would give to a patient or a family as they're kind of preparing for that transition phase? What would be one piece of advice, of maybe something that you wish somebody had told you prior to that transition?
So I guess I would say, let me think, one piece of advice. What would have been important to know is that I think it's harder many times on the parents than it is on the patient themselves. So, for example, my mom took me to every pediatric cardiology appointment usually, and then I wanted to take myself to my new appointments with my cool new ACHD specialist, but I had to remember that this has been her life for my entire life, for both of my parents. And while it was difficult on me to transition from my pediatric to my adult congenital specialist, I can't even imagine how difficult it was for both of my parents, just because we were leaving the comfort of what they've known forever. I didn't remember my surgeries, but they do, and moving onwards. So though I do want to be my own advocate and would suggest everyone be their own advocate, it's also important to include your parents throughout the process as well.
Okay, I want a copy of this tape so I can give it to Alex.
And how about for you, Anna? What would be what would be one piece of advice for a parent that is prepping to send their child off into the unknown by themselves?
Well, I think really you have to trust your child, and you have to give them an opportunity to make mistakes, and that is really, really hard. We are so used to making the appointments, getting the medication, taking them where they need to go, that it's hard to give them the opportunity to miss an appointment, because we don't want that to happen. But you know what? I think that sometimes that has to happen. You have to let them experience their own consequences for what they do. And we don't want to do that as parents. We want to make everything perfect. Everything's not going to be perfect. I know for me, I've missed some appointments at certain times, and then I have to reschedule, and I have to do the adult thing and take care of myself. And why should my son be any different? I have to allow him to make his own mistakes. I have to allow him to live his own life and not put too much pressure on him. Now, do I remind him frequently that he needs to see his cardiologist? Yes. Do I do it every single time I see him? No, because I want to have a good relationship with my son, and I understand that unfortunately this is not as important to him right now as it is to me, and I just have to give him some room to be himself and hope and pray that he is going to get back in care. The lag won't be too long, and that he knows I'm here for him when he needs me. And I just have to trust that everything's going to be okay. And I think that's a hard thing for us parents. In fact, I belong to a Facebook group that's just for parents of adults, and this is something I've heard that other parents say as well.
And I think I'm glad that you mentioned the Facebook group, because I know that having support has really helps our patients. I know we often I'll send them to Facebook or some other, even ACHA has opportunities to go and be hooked up with some patients with similar defects. And I think that that's important, because I think sometimes they feel so different, And, you know, even though, Anna, you talked about framing it as a chronic illness, which it is, I think still when you, and Marissa, I'm sure you can speak more to this, but, you know, I think sometimes you feel different, and I think maybe some of those gaps in care, those lags in care, are just wanting to feel normal because you feel okay. And I think being able to connect with like people is so very important. But I think we are about coming to an end of our chat. It was so nice speaking with both of you. I really would like to thank both of you for joining us and certainly sharing your experiences. I know putting all of that medical information out there isn't easy. And finally, I would like to thank DeBakey Education for this opportunity, and because this is such an important topic, and I think something that you know, we won't have the definite answers to for quite some time, but we can work towards making transition smooth. And we look forward to seeing all of you on another episode of CV Live to discuss more about our complex ACHD patients. Have a good evening.
Thank you so
Thanks,
much.
Amy.